Welcome back to Online Anesthesia. Anesthesia update in Zoom platform, sponsored by Akrula and hosted by A1 Logic and co-sponsored by Anaesthesia TV. Today we have two topics on recent advances in anesthesia. The first lecture is recent advances in anesthesia gadgets by my good old friend Dr. Tushar Chokshi. He is internationally well-known faculty. And that will be followed by a lecture on recent advances in anesthesia drugs by a well-known international blogger and teacher, Dr. Unnikrishnan from Kerala. Today's session is coordinated by Dr. Sivaprasath, our team member. Over to you, sir.
Thank you, sir. Good morning to everyone. Welcome to the third edition of our anesthesia update. And true to the update, we have two important topics. One is on the gadgets and the other is the recent advancement of drugs. And we have two eminent speakers, well-known speakers. Welcome, sirs, both of you. And the first speaker is going to be Tushar, sir. He is very well known to everyone, postgraduates as well as consultants for his infographics. He has done his MD from Baroda and is practicing there for the past 32 years. He is very innovative. He is taking up a lot of urology and laparoscopy cases, and to that he has added opioid-free anesthesia and TIVA, and his innovations have come out as two interesting societies, the ISOFA Society and the TIVA Society. He is the founder of TIVA and OFA societies in Facebook groups, and he also has some interesting other than anesthesia, like he has some origami teaching. He also has storytelling virtues. So we are excited to have you here, sir. And we have a lot of expectation. We'll move forward to your interesting gadget session, sir. Welcome, sir.
Thank you, sir. I'm sharing can you see my slides?
Yes, sir.
Okay. Now I'm very much delighted to speak again on this platform with my very good friend, Dr. Edward Johnson and his team. I'm Dr. Tushar Chokshi, as given by good introduction to my friend. And it is this topic is still in my heart since last 10 years, and I'm very innovative. And every day I'm founding new and new inventions in anesthesia, from basics to artificial intelligence to metaverse to nowadays in ChatGPT. I'll go on the second slide. Just a minute. Meanwhile, this presentation is with the picture format, and more for this slide presentation, you will see the very good photographs of the day-to-day monitors, vital parameters, and they are run by the smartphone apps, and our anesthesia machines, vaporizers, TCI TIVA machines, everything. I'm not able to move to my slides.
So just click inside the PPT, sir, once. Anywhere.
Okay, can you see my second slide?
Yeah.
Okay, now topic is breaking advance of gadgets in medical and anesthesia practice. So my disclaimer is that this presentation is for medical information and knowledge. It specifies that it helps in medical practice, and the use of this innovative and newer gadget informations are subject to individual preference. Further, users are advised to seek professional medical assistance if they want to use. So each and every gadgets are unique, and if you want to use it, then either go to internet or YouTube or in the Amazons or whatever the way, but you have to first go through the details of that gadgets, and then you can use it. So our gadgets are classified as a pre-operative gadgets, medical gadgets, simple medical gadgets, anesthesia related gadgets, post-operative gadgets, operation theater related gadgets. It includes ICU, non-ICU backup, whatever it may be. So this presentation is more on pictures with short description of innovative gadgets. So enjoy this lecture. And I had given this lecture more or less more than 50 times in all over world. We will start with the very basic parameters like blood pressure. Now you see that blood pressure, we take it non-invasively, invasively, but these are the unique blood pressure, smallest instrument. Like first you can see the finger blood pressure monitor, where you can put the fingers on the smartphone. You can put a finger like this. You can put on the this type of the machines, and the blood pressure measurement comes in the smartphone or directly on the screen. And that type, wrist type blood pressure or watch type blood pressure instruments are available. And even cuffless blood pressure like free scan, you just put on the radial artery and then it can show. I have this type of the instrument like wireless blood pressure monitor, and you can use on smartphone app through iHealth. iHealth came out with the so many vital parameters individually. So these are the blood pressure instruments are available in the world since last 10 years. These are the thermometers, smartphone attached, Medicina thermodoc infrared thermometer. You just attach a small things of thermodoc in your smartphone. Any type of smartphone you can attach this type of the, you just put on the LED light and you can have a thermometer type of the reading. And this attachment is coming in the only 3,000 rupees. And this type of the attachment directly attached with the smartphone. It is called multifunctional smartphone infrared thermometer. It supports human body, water, food, environment. It is also used in the commercial purpose. And if you have pediatric patients, and then you can go with the Kinsa type of the thermometer, where you can have the smileys, or you can directly put in the ear. There is a ear probe, then tells your temperature and offer really time guidance to what to do next, tracks fever, symptoms, medication, and diagnosis. Then there are smart weighing scales are available. This is the only iHealth core smart weighing scales are available in the world with smartphone operated, which measures 9 parameters of like weight, lean mass, body water, bone mass, muscle mass, body mass index, body fat, visceral fat rating, daily calorie intake. Just you put your legs on these machines and they will measure your weight and height by the laser, this laser light, and then it immediately shows you on your smartphone everything. Then our basic parameters, pulse oximeter. We have seen the watch type of blood pressure instrument like wrist pulse oximeter. Then ring pulse oximeters are just like you put a ring over the patient's any finger and it will show the pulse oximeter. Then for the neonatal purpose, they are having this type of the neonatal disposable pulse oxygen prometer. And even iHealth came with the wireless pulse oximeter, where you can have, I am having this pulse oximeter since last 8 years. It accurately measures SpO2. It is rechargeable and it costs you only 1,500 rupees. It accurately measures SpO2, HP, HR and perfusion index with wireless pulse oximeter. This iHealth company came out with so many vital parameters, very small size run through the smartphone. And these are the pulse oximeter, eye oximeter. You have an attachment directly, you can attach with your Android phone or iPhone and probe directly attached with the smartphone. It will show you in the result in your smartphone. Then pulse oximeter, the near field communication. All the smartphones are having this type of the app in near field communication, and pulse rate from ST pulse oximeter device through NFC interface, which will directly show in your smartphone and smartwatch. There are disposable SpO2 forehead sensors are also available. It is used for up to 2 days in the pediatric patients or in the ICU patient. And if you are having a weight anesthesia practice, then the tongue probe are also available for your pets. Then Biobit company came with the measures pulse oximeter and blood pressure both the way in your watch. And in next successive slides, I will tell you what type of the Apple Watch is coming in the market in within 6 months. Then maximum IT sets pulse oximeter, it shows you SpO2, pulse rate, plethysmo index, then respiratory rate, everything. And it is Bluetooth wireless and which can connect. And now I have seen that this pulse oximeter is connected with Wi-Fi and distant places. If your distance in teleanesthesia patients are wearing, your near and ears are wearing this type of the pulse oximeter, then you can see even 100 miles away from that destination in your smartphone. And that Massimo came out with the new rainbow light sensor with oxygen reserve on index that measures the advanced warning of impending desaturation. And if you are having a cardiac arrest patients at home or in the theater, then you have a nose clip type of this instrument. It tracks heart rate and respiratory rates in multi-trauma victims, and it clips on the nose and immediately begins to monitor. It shows the respiratory movement, and if there is no airflow, then it does not show anything on the reading. Then handheld pulse oximeter with NIBP. These are the very palm, like size of the palm, these ambulatory. These are the smallest instruments are available in the world. Then contact 08 digital blood pressure monitor with SpO2. This type of the pulse oximeter with blood pressure I'm using since last 7 years. Then Barton's handheld pulse oximeter with capnograph. This is also very unique, available in 50,000 rupees only in the world. And these are the two probes are coming out from the one wire, and it shows both the way, pulse oximeter and capnograph. It is a very handy one. Then Smith's Medical came with the handheld pulse oximeter with capnograph with separate sensor for capno check. And believe me, this is the Massimo Emma handheld ETCO2 monitor, which is the world's smallest size of 2 inch only capnography machine. It is costing around 1 to 1.5 lakhs rupees, and it is only just like one finger size. And it is used for the short and long-term monitoring of adults, pediatrics, and infants. So what else you required in our gadgets? And there are some changes in the smartphone stethoscope. These are the stethoscope approved by this Food and Drug Administration USA. It is Y-scope. It's smartphone enabled. It directly shows all the phonations on the stethoscope. And this type of a thinking, just plug and play. Small power. These are only small, this type of the chest piece, and you just put in your headphone or in your smartphone. Then Ecuro, the first smart electronic stethoscope. Even Ecoscope came with the integrated electronic stethoscope with electrocardiogram. When you put over the chest, then it shows the 12-lead ECG. Then smartphone ECG machines, these are like this world's first ECG machine which delivers hospital-based quality ECG, Cardio Defender. These are the 21st century heart monitor. It shows all these readings by your wearing the smartwatch. Then this machine like AliveCore, available in 7,000 rupees in Amazon. It is called a Cardia mobile EKG, which if you put in your Android phone or in your smartphone behind this smartphone, then it shows, you just put your in palm like this and it shows the ECG. Then Mobmon, 1 lakh rupees, smartphone based ECG of 12 lead and with pulse oximeter. Just put in the your smartphone, it starts with the taking the ECG. Then believe me, this type of the watch is in the pipeline by Apple and Samsung. Near future multi-para monitor with smartphone. What it shows? It shows SpO2, it shows heart rate, it shows everything, emergency call, ETCO2, glucose monitoring, NIBP, patient ID, temperature, everything. What else you require? And believe me, there is some sensors released by the Apple Watch, that Apple company, that this Apple Watch will replace our ICU monitor in near future. Just your ICU patients and your OT patients have to wear this watch, and you can distantly with your smartphone, with your distance tele anesthesia practice, you can see all the parameters in your distance screen by Wi-Fi, by metaverse or whatever. And these are the smart defibrillators. This is Indiegogo that was developed in Australia. These are the smartphone based automated external defibrillator. When there is you carry with this type of the smartphone, then there is a victimized patients in whatever the trauma patients in your market, mall, or in your roads, and then it will easily come out from the behind this smartphone, and first it activates the emergency call from that country, and it immediately censors the activates and guides you, okay, what to be given, how much shocks to be given. Then these are the Bluetooth wireless heart starts. It works on presenting ventricular fibrillation and determines the initial therapy. Either you have to give shock first or CPR first. And there are implantable defibrillators are available in the world, and Harvard Medical University is the first in the world who has implanted the defibrillator. If you are having a cardiac arrest, then it will pop up your heart signals from inside your body, and there is a hardly chances of cardiac arrest. So these are the new invention in the defibrillators. And these are the rescue pump, this rescue pump and rescue POD. It delivers optimal chest compressions, and this type of the machines are available. And these are the trick spike. It speeds up the process and leaves less room. These are the new CPR inventions in the world. Then there are smart glucometer. This category of the glucometers are going in the world very prominently. These are the thermodoc, like glucose monitoring system, which wirelessly works with the smartphone. I have shown you the thermometers that like that glucodoc available in 2000, 5000 rupees with you attach on the smartphone. It will show you the directly on the smartphone. This type of the attachments are available on the Amazons, and you can put, you have to put the strips like. Then these are the glucose, non-invasive blood glucose concentration to be measured at the capillary level. You do not have to prick yourself, just glucose level extracted by the non-invasive technique. And this is Dario glucometer. You have to put an app in this, and Dario is a warm color gadgets which includes much more than a regular. There is a lancing device inside this. So these are the new gadgets for the, and these are the sugar beads, which are, even I have put this sugar beads for the 1 month. This is continuous glucose monitoring, and it available in 3000 rupees or 10,000 rupees. If you want to wear this type of the watch, then it directly shows your blood glucose monitoring every 15 minutes for at least 1 week, 2 weeks, or 4 weeks, and you can monitor your glucose. Then Novosense, these are the tier glucose level. You just flexible oculars insert glucose measurement. These type of the device measures minute changes in the glucose level in the tears. From your tears, it will show your glucose. And these are the smart contact lens glucose monitoring developed by Google and Novartis company. You just wear this lens in your eyes, and it will continuously showing your glucose monitoring like continuous glucose monitor every 5 or 10 minutes. This type of the spirometers are available. Now it flawlessly connects your smartphone, and you can blow in this mouthpiece, and you can have these results on your smartphone. And these are the non-invasive blood analyte monitors for measurement of the blood hemoglobin. Non-invasive. It is developed by Orsens. And this type of the RED 47, it measures SpO2, pulse rate, perfusion index, and everything. And all type of the hemoglobin parameters. Pronto pulse oximeter, it also measures oxygen, pulse rate, plethysma index, SpHb. Titocare is for the tele-anesthesia practice and for the routine pre-anesthetic checkup for telemedicine. This device includes regular stethoscope, thermometer, otoscope, built-in camera, and tongue depressor. So for a patient for your pre-anesthetic checkup, it is a best instrument available. This available around 12,000 rupees in the world. And this is a very much going in the Western countries like in Israel, then in European countries. Then these are the vital patch. If your patients are in the ICU or in your recovery room, so band like disposable vital signs monitor shows result on smartphone. It measures single ECG, lead ECG, heart rate, RR interval, respiratory rate, skin temperature, fall detection, and body posture. Even sweat sensors are also, they can measure everything. Now sweat sensors are going in the 3rd generation group, and they can measure even distantly, where you have this sweat sensor includes a Wi-Fi and Bluetooth connections also. And you can measure it for your elderly patients at home or whatever it may be, everything by your parameters. These are the smart vein finders, not routine vein finders. You can have this type of the Google Lens. You can wear this ultrasound IR glass for your venipuncture, and you can have a 2.5 lakh rupees of this type of instruments where you can have very micro vessels also. You can detect it out. There is a tap at blood collection system, nearly painless blood collections by wearing this single-use device, and this will not prick your vein. This is vascular new needle-free blood practice, new version of needle-free blood draw device. Patients already on peripheral IV do not have to undergo additional venipuncture. I have not seen, but this is a very good invention in the collection of the blood. And these are the biodegradable polymer coating that can plug an injection site called chitosan. Blood loss after injection is prevented. And our Venflon invention is not also going behind. There are so many safety injections and Venflons are available in the world. Like these are the peripheral IV catheter available in wide range of from 16 to 26G. It reduces the risk of exposure to blood, patient's blood. There are 2 IV port, and you can use like a Venflon. Then this is a IV cannula with integrated 3-way. You see, this is when you remove this stellate, then it forms an umbrella like this safety needle. So you incidentally or accidentally cannot prick the needle in your body. There are the safety IV cannula where you can just put a Venflon in the body and the stellate comes in the backside. So it's our very safety Venflons are invented in the world. And these are the Mahurkar smart syringe. These smart syringes are invented by our scientist in India from Pune, Dr. Mahurkar, and these are the not possible to reuse. See, this needle comes in the plunger only. So needle holder is locked to the plunger. After use, the entirely syringe is interlocked. So there is no use of reuse of these syringes. And these are the adhesive bandages. Adhesive bandages are available as a AirTag waterproof bandages. Come with the anticoagulant, antibiotic, antifungal, and water remote. It releases a multi-compound therapeutic substance onto the sterile pad. So these type of this band-aid are very much popular in our India and western part of the countries. And for this, our anesthesia purpose, anti-snore devices. Sometimes in TIVA and MACTIVA, this type of the chin-up machines are available. Means these type of the hold-up are available in Amazon. It costs only in the 580 rupees. Patient survey support. These are the smallest CPAPs available in the world, anti-snore devices. And these are the anti-snore chips support strap belt. These are home use for, and sometimes it may use be for the OSA patient. And these are the clips are available. It gently opens the nostril to increase the airflow. Built-in magnet provides magnet therapy, and it's non-invasive. These are the snore clips. Only 85 rupees on Amazon and Flipkart. Then some endoscopy mouth guard and mask for the innovations like Ovation fiber optic intubation airway. From this, you can have an endoscope insertion. Then VPN endos mask. These are the application for fiber optic intubation, bronchoscopy, gastroscopy, and transesophageal echocardiography. This endoscope goes from this mask, and you can have a IPPR or assisted ventilation, or you can put from here the oxygen also. And these are the oxyguard. There are, see these two prongs on the nasal, and these are from, so it is a unique oxygen nasal pod, oxygenating mouth guard. From this mouth guard, I'm using this mouth guard since last 10 years, and I'm very happy with my gastroenterology practice. It delivers oxygen from both the mouth and nose. And these are Penny's mouth guard for ERCP anesthesia, which has got a capnography as well as oxygen attachments. And it fits on the patient's mouth. So our ERCP and gastroscopy procedure becomes very easy. Now endoscopy, supraglottic devices are also available, like LMA gastro airway and gastrolaryngeal tube. These are the two tubes now available in India, around 22,000 rupees. And I am using this type of the gastro LMA. And for a fiber optic ERCP, means gastroscopic ERCP patient for a half an hour to 1 hour. And my patients now very safe. So different nasal and ET tube. These type of the nasoflow, nasopharyngeal airway tubes are available. It allows for the direct oxygen delivery. And there is an optional respiratory indicator where you can measure the capnography also. And these are the endoflex endotracheal tube, where you do not have to put a stillets in this tube. It can with flexible with retroflex or flex. So these type of the tubes are available now. This is hyaloid microcrop subglottic suction adult endotracheal tube. That is a separate port than cough pressure. There is a separate port for the suctioning. So you do not have to detach this from your circuit and suction it. There is a subglottic separate lumen, and you can suction from your trachea. And these are the nasal tube and endotracheal tube, your jet ventilation invented by Chinese people, WEI nasal jet tube and WEI jet endotracheal tube for the jet ventilation. It delivers up to 70 liters per liter. And these are the 3M's new Durapur advanced surgical tape for the keeping tubes in place. This new product suggests to skin various tubes and itself when the surgical surface is made. This is a very good invention by the 3M. And our different McGill's forceps are available, like Rodinia, Tilke Mercury. You see, this is a catch in this. You can catch this your McGill's tube, and you can insert in your trachea with easier and safer nasotracheal intubation. And our routine laryngoscope are now available as a Macintosh switch style laryngoscope. So there is no accidental detachment of this laryngoscope from blade from your handle. And in pediatric anesthesia, centered anesthesia marks for pediatric patient, which available in raspberry, then pineapple, whatever the this centered scent mask you want. Then suppose your child wants a rose scented or pineapple or this blueberry, whatever this type of the masks are available. It improves patient tolerance and reduces patient's children's pre-anxiety. And these are the these are type of the mask, nasal masks are available, designed to optimize comfort, minimize the anxiety, lightweight and stays out of the way. So it is just a nose mask. These are the masks available in the western part of the. And you know, this pediatric anesthesia SedLine monitor, it assists the maintaining the proper depth of the anesthesia in the pediatric patient. And this is now one of the very well established Sevo, the dragon user fire breath. There is a Sevo beds are available. Their children are playing in the screen, and immediately they have to wear a helmet here, and that from one part of the helmet, the sevoflurane is going on, and they play from your helmet this screen with the dragon, and immediately they will start, they blow the air in this helmet, and the sevo will be inhaled. And from that, so actually video game is actually played by the child on a screen attached to the front of the wheel, hospital bed, to inhale, exhaling the sevo in mask. It's a very good invention in our pediatric anesthesia, where child will, by playing, they will go in the anesthesia. And these are the smart video laryngoscope. I have invented this video laryngoscope through smartphone just 7 years back. Now the cost of this video laryngoscope is only 700 rupees only, rather than 2 lakhs rupees our old new video laryngoscope. This Android boroscopes are available 300 to 500 rupees on the Amazon. This smartphone will act as a monitor as well as light source. You directly attach on the Apple phone or smartphone, Android phone, and you can connect with your this laryngoscope, and it acts like video laryngoscope like this. This is a blade, and this is my iCard, visiting card, and I can see in my smartphone. And this is the first laryngoscope built-in suctions available in scope for the video laryngoscope. And these are the disposable video laryngoscope. Now there are so many players having, in India also it is available in 3,000 to 5,000 rupees for single use by so many companies. And this is the first robotic tracheal intubation in the human, which was invented in 2012. Now it is going very much advanced through artificial intelligence. Even in metaverse, I can intubate my patient from here, from Baroda to even Kanyakumari with this type of the instrument. And this is anapenograd, which measures automatically cup pressures. You know, this cup pressure is very important in our anesthesia practice. If your patient is having a high cup pressures, then there are so many problems you cannot recognize in your post-operative period. And these are the rapid positioning intubate stylet. In dynamic, there is intubation with control tape, which flex and retroflex. This is a very good instrument for intubations. And these are the smart USG machines now available. Our India has not recognized this, but in western part of the countries, this type of the attachments, smallest attachments are available. This butterfly IQ is very common in all the card. You just put a software, download software in smartphone, and you have an attachment with your iPhone or smartphone, and you just go with the 3.5 hertz with those type of Philips, Siemens, and so many companies came with the smallest size of the smartphone USG machine. And now our regional anesthesia is also far now. In anesthesia, Equip company came with the Neuropol echogenic needle, plexus needle, which with the latest ultrasound reflection technology. Then if you are alone to give your regional anesthesia or blocks, then single anesthesiologist administer regional blocks with the Safira, safer injection for regional anesthesia. Then even in your block, in your these workshops of regional anesthesia, any block workshop, then spinal simulators are also available that will show how to place needles for blocks. Asterisk. Then epidural space locator machines are available like Accuro, then Equip, that will show you the how much depth for epidural space is there. Exactly you can. So there is failure when you put your spinal needle or epidural needle in your any type of the patient when you are giving regional anesthesia. This is CompuFlow, able to provide epidural anesthesia system. Means it preserves that the needle, the pressure, and it provides precise and continuous measurement of the pressure at the tip of the syringe, both helping to guide the anesthesiologist. And this is the smallest size of the these epidural scopes are available from Apixi, and it is 120 doing 20-degree viewing angle. It is hardly 1.5 millimeter. It is much used by the all pain specialist physicians. And now our anesthesia trolleys also got transformation by not having electrical connections, like our oxygen concentrator directly attached here, and this trolley will be run its oxygen by only from the air with the help of oxygen concentrator. These are very good invention for the distant part of the means very remote side of the countries, like African countries, remote part of the anesthesia theaters like that. And these are the depth monitor invented like QCon, Conox, and this opioid monitors like NOL, nociception level. These are the depth anesthesia monitor for the TCI TIVA. And there are so many inventions are going on the BIS monitoring also. These are the anesthesia workstation with agent management features. See, this machine, world's most advanced anesthesia workstation costing 1 crore rupees, which was invented by one of the major players in the world, that only India is having 3 machines in the this, and there are more than 50 machines in the world. And it goes whether from these machines, you know, these are the machines invented by this company with the Wi-Fi, internet, and Bluetooth. And this even to think that to kill the patient is very much difficult with this, and it cost around 1 crore rupees. I have seen these machines in my Baroda is very fortunate to have this type of the machines, and this machine is very advanced machine. They have all the monitors with TCI TIVA machines, and every monitors with there is no gas like the flow meters, and that everything feather touch. Then my dream of only future artificial intelligence vaporizers, this is in the pipeline, where all these vaporizers are formed in one vaporizer with all the tanks like desflurane, isoflurane, and sevoflurane in one vaporizer. You can choose from your only one vaporizer will be mounted in the anesthesia machines, which I have shown to all part of the India recently. And this is the universal TCI TIVA pump for all your drugs out there. Just recently, one week before in Coimbatore, we have inaugurated this. We have released this pump from Elevate Acromed company, and these are all the drugs are softwares are in this only one pump. This universal TCI TIVA pump can be used for all drugs, like you name all induction agents from fentanyl to remifentanil to midazolam to even dexmedetomidine, ketamine, propofol, everything. You can use single pump for every drug. And this is my future anesthesia workstation, which only have a one, like we are in the pipeline of, see, I have shown you 1 crore rupees of machines. And in these machines, in 2030, I dream that there is a switch on, switch off anesthesia, where you have only one button, asleep or awake. When your patient is going for anesthesia, you just put these machines on the asleep, then patient goes in the anesthesia. Then when the surgery is over, you want to wake up this patient, then put on the machine on the awake mode, then your patient will be totally awake. And if in between, if you want to relax, then you can have a kiosk of this coffee or juice or tea. So this machine is in my dream, and believe me, this I dreamt this 10 years before, and in 10 years of the span, anesthesia inventions in gadgets and are going so much tremendous changes with artificial intelligence, metaverse, and now chat GPT and DALL-E 2, that everything is under now not dream, but it reality. And patient came with the 2 surgical gloves in one gloves. Like inner glove is bright green colored, and while the exterior one is natural skin color. If the exterior gloves is damaged by scalpel, then for example, the green from the glove below suddenly pops up. So it's a very safety measure for our H1N1, HIV, HBsAg positive viruses when we are operating all this. And this is the smallest size of the ventilator invented by BD, that even smaller than A4 size. The beauty is that it used from the street to stretcher to air to NORA to OT to ICU, and it supports invasive, non-invasive, and transplant ventilator. And this is integrated with the pulse oximeter. I have seen these machines and very small, just A4 size, below A4 size of the paper. And if you are in OT and your surgeon is shouting that increase the light, height, adjust the OT table height like that, then you have a smart Wi-Fi OT gadgets with your smart remote switches. This type of the switches you can put in your OT, and you can connect your smartphone, and If he says that can increase the intensity of the light, then you can order your smartphone like Alexa, Siri, or Google, or Bixby, whatever, just increase the light, head down, head low, like that. So these are the reality now. And for disinfectant of this your OT, the light targets naturally occurring molecules called porphyrins, which sterilize the OT very prominently. And these type of the digital plasters are now invented, device meant to be embedded in the ordinary plaster, and this contains Sensium silicon chip powered by the small battery. And these are the Vitti gel is now available, like our cyanoacrylate gel that stops bleeding in seconds. It is very much helpful in when there is a high bleeding in the operative site. China people came with so many infusion pump in a one pipeline, like 4 or 6 infusion pump. These are available in the world. Drug release in sticky patchy pain relief, the novel polymer technology about ibuprofen. And this is, I called it as a cold cautery. It's a bioweld. It's a unique device to seal surgical incision using cold plasma gas. It ionized particle plasma have been shown to weld human tissue. And it is a very, we have seen our electric cautery. So this cautery is now available and it seals the edges of the incision. And RIBA, our stretcher is also invented by world's first robot that can lift up the human in arms. It is called Robot for Interactive Body Accessory. RIBA is the first robot that can lift up or set down the real human from bed or wheelchair. If this robot is in your hospital, and suppose your hospital's bed is in the 3rd floor and your OT is in the 5th floor, just you give the order through your smartphone, this robot comes through lift and they will catch your patients and they will send it this patient to your OT, and they will take away from OT to recovery room also very safely. And this type of the beds are also available. These are the wireless beds, and from smartphone wirelessly artificial intelligence they can run. They have everything. They have monitors. They have connected. The beds will stream parameters. Every parameters can be. This bed can, you can like this RIBA. You can order this bed from your ground floor to any floor of your OT from your hospital, and they can come in your way and you can transfer this patient from this bed. And by even moving this in transit, you can monitor your patient with vital parameters in your smartphone, whether you are in the 12th floor or 1st floor. And for your this electric underpants are available for your this bed source, and it activates muscle and increase the circulation in the area and effectively elevates bed source, thereby saving life. This is very good invention for the ICU patients. There we have a lot of bed source when their patients are ventilator. We can see with so many good ICU care. So if this type of the pants are available, half pants, then patients are safely protected with the bed source. And even these are the somatome and portable MRI. This MRI and this CT scan both can be built to your patients nearby their cot. So patient do not have to transfer to CT unit or MRI unit. This can then come to your hospital. They are very small, like our anesthesia trolley, and you can plug in your this any bedside, and you can have this CT scan and MRI. Even MRI compatible infusion pumps are invented. Even biolung machines are invented to remove the CO2 in your any COPD patients in post-operative, also hemolung respiratory patients. It saves patients from sedation, intubation, ventilator associated pneumonia, and other complications. These are all machines are available in the world. Closed loop anesthesia delivery system. This is invented by our Indian scientist and anesthesiologist from PGI Chandigarh. And these instruments, this closed loop anesthesia, there are so many infusion pumps are attached in the periphery, and you have this type of the anesthesia depth monitor. In between there is a computer, and computer will decide with this two of these peripheral things that how much anesthesia to be given to your patient. So it acts as a closed loop anesthesia delivery system. It's a new invention in anesthesia. Even medical variables are available in the metaverse, and these medical metaverse are very much helpful in our pre-anesthesia checkup. Suppose my anesthetist friends are asking my assistant from distant OT from any part of the India, then I wear the HoloLens and I can assist him by avatar in that theater. And it is not far behind. It is called as a transcontinental anesthesia or distance tele-anesthesia practice. It's a reality now. You just wear the MetaWatch or haptic gloves, or you can have Meta cap or Meta t-shirts. So metaverse is also coming in the big way in the as a gadgets for anesthesia, pre-anesthesia checkup, education of the patient, then virtual anesthesia practice, then in seminars, digital as acting as a digital metaverse anesthesiologist. What else you required? See, these are you can create your own metaverse theater by having all this. The basic instinct is you have to wear the HoloLens or this Microsoft lens, and you can work as an avatar with your virtual anesthesia assistant in your another anesthesiologist friend's OT. So in the take-home message, anesthesia is a very developing field in the gadgets, and they are divided in advanced monitoring system, use of ultrasound technology to guide region. See, in ultrasound also, artificial intelligence, if you are not well versed in your ultrasound, knowledge, so what ultrasound says by artificial intelligence, you show me the anatomical structure, I will identify whether there is a small nerves, small muscles, and I will inject this nerves and I will block it. You show me by artificial intelligence. So there is no need of going in even now for workshops and everything. I don't know the sonography machines details in my regional anesthesia practice. So artificial intelligence and metaverse comes in the way. Remote anesthesia delivery system. So now there is no like workshops or will go away within 10 years, and everything will be remotely. Workshop will be like one anesthetist join from Kashmir. I will join from Baroda. Dr. Edward will join from Kanyakumari. So everybody will gather in one as a remote anesthesia virtual theater, and they will work as a workshop leaders. Then new drug delivery systems are also coming in. New drugs are invented from since last 10 years, like Ramimizolam, then Ciprofol, then everything is a Duzitols and Heptiva. So anesthesia, see, 200 years before there is if you give 100 anesthesia, then the death rate was 10 per 100 anesthesia given. In 200 years, hardly 0.1. And in coming 10 years, it is very, very difficult to kill the patient with these type of the newer gadgets. And believe me, anesthesia is becoming more safer than any part of the world of any medical specialty. Thank you.
Wonderful lecture, sir. Really, after hearing a lecture, I feel I'm way back in time, sir. So many gadgets, right from simple thermometers, finger pulse oximeters, beep apparatus, stethoscopes. So many things have really changed a lot, sir. And we are yet to
I have worked for 7 years to prepare this.
Oh my God.
Yeah, I have collected more than 2,000 gadgets. And for medical gadgets only, but for anesthesia, I had put this. My slide presentation is more than 500 presentations, means each slide, but I have selected only 60 for time limit.
Really, you're lucky today to have seen all
Thank
this.
you.
If not for you, we won't know more than what is a maximum monitor, sir. So much is there. We don't know all these things, sir. Thank you very much, sir.
And 40% instruments are available in the world now.
That is even more interesting, sir. Sometimes
and you won't believe that I want to tell one thing, that yesterday only I was telling with my ICU physician that now all monitors will go away from the ICU and only patient have to wear watch only, and it will be distantly measured by workforce. It becomes a very much safe for this. You can centrally monitor, you can monitor from your home, you can monitor from a distant part of the world. And like our CCTV camera, you can watch your CCTV hospital camera from your even distant 1,000 miles away from your home or hospital. So the technology is going very far away now.
Thank you for this
Thank you,
lecture,
sir.
sir.
Thank you. I'm
For
very
your
delighted to
vast
give this
knowledge and
lecture.
long duration. It's not take 1 2 years. It's taken 7 years to prepare this, and given this in a 45-minute lecture. We are
Thank you.
really happy to hear this, sir.
And I'm
Thank
very
you
happy
much, sir.
for Edward, my very good buddy friend, and I'm proud of you, Dr. Edward. 3 salutes to you for your continuous this webinars and everything. Really mind blowing. Nobody can do in India.
Thank you. Tushar, Parthasarathi asked whether we can give anesthesia at same time in 3 OTs with these new gadgets.
See, I'll tell you, you can monitor your patient. Our anesthesia attendance is required. See, all these gadgets are there, but our tactile and dexterity based labors will not be go away. So they cannot take the decision. We can monitor the patient. Suppose if you want to extubate the patient, then you have to give the orders. So that's the way. Artificial intelligence is there, no doubt it. But for that also you have to feed something. Ne? So this is the only branch where our anesthesiologist presence are. So always I'm telling you my artificial intelligence and metaverse lectures also artificial intelligence will not take our jobs. We have to be present. No doubt. You can run 3 theaters by 1 anesthesiologist with all these gadgets and your anesthesia technician. That's the way. I run 2 theaters simultaneously with my anesthesia assistant. No doubt it. Very safely.
Really, on one side, it looks like all these gadgets may replace us, but human mind and human effort
human
can
mind
never
is
be
to be
replaced.
there.
Can never be replaced. It's totally different. We are
I have
using
not
these
told,
gadgets
I
for
have
our
not told
use.
about the chat GPT because chat GPT, so many people don't know about this, but chat GPT is a new invention after metaverse also, after artificial intelligence. You name it, it can draw. You name it, it can see. Whatever suppose this lecture, if I want to prepare myself for 7 years, then chat GPT will prepare within 7 seconds only. That is the beauty of chat GPT now. Human mind is going extraordinary with this artificial intelligence chat GPT. So thank you for all these things. And is there any question? Then I am ready to answer.
We'll look into the chat box, and if there is anything, I'll ask you again.
Okay.
These gadgets are very new to our viewers and for us.
Now, I will give you this link, whole gadgets slide presentation to you personally, and I'll put in our group also. Okay. Thank you.
Thank you, sir. Thank you very much, sir. The next presentation is on newer drugs by Unnikrishnan, sir. He is the head of neuroanesthesia in Chitradharnal Medical College.
I am not the head of anesthesia. I am an additional professor.
Additional professor, yes, sir. Sir is well known with his anesthesia blog as a medical layman, and he is an excellent teacher. We are waiting to hear from you, sir. Welcome, sir.
Is the slide visible?
Yes, sir. It's visible, sir.
Thank you for the kind introduction. I owe my thanks also to Edward Johnson, sir, and the online anesthesia platform for giving me this opportunity. So I am Unnikrishnan from Sivaprasath Institute for Medical Science and Technology, Trivandrum. I am working there in the Neuroanaesthesia department. So straight to the topic. Before that, since all these are newer drugs, just like Tushar Chokshi, sir, I also need to show the disclaimer. This content is only intended as a teaching material for students, and please refer other sources for clinical practice. So whenever we hear about such a topic, new drugs in anesthesia, the straight question which will come to our mind are which are the drugs. But a better way to face the topic is when you include in the background why we need such drugs. So that will give a clear perspective of the importance of the new drugs and the pitfalls. Are the existing drugs perfect? That is the first question. See, everyone knows the most commonly used the induction agent is propofol. but propofol has that issue, that is hypotension. So the etomidate and ketamine have a remarkable capacity for supporting BP in compromised patients, which the propofol won't. However, other shortcomings make these drugs inferior to propofol. And we also know that respiration is less affected by etomidate, ketamine, and dexmedetomidine than by propofol. So there are lacunae in the profile of the existing drugs. And another thought is, can benzodiazepines be used as anesthetics? So there has been a lot of trials in the past, quite some time back, where they tried benzodiazepines as anesthetics also for induction and maintenance. But the one major problem they found was a high variability in drug response and drug requirement. So one patient needs very less drug to get anesthetized, another patient needs a lot of amounts for getting a proper plane of anesthesia. So this individual variability was a major hurdle in using benzodiazepines as an anesthetic. And a relatively slow onset of action. So you can imagine how an anesthesia onset will come if you give a larger dose of prednisolone in place of propofol. So it's not that fast, and the long-lasting residual effect. So many times, what they needed was they needed to bring in flumazenil to prevent resedation. So that was a major issue. And again, even for anxiety now, psychiatrists give benzodiazepines with a hesitation. That is because of the dependency. The another problem is tolerance and tachyphylaxis when you use these agents for quite some time. So benzodiazepine as an anesthetic, the image is somewhat tarnished. So but there have been there is a slight comeback for benzodiazepine group into the group of anesthetics, because they are the recent research is now slightly focusing into benzodiazepines with affinity for alpha-2 receptors and alpha-5 receptors. But no major molecule has come in this regard, so I'm not mentioning about those molecules here. And in this era, whenever the researchers go for a new molecule development, they first see what are the recent expectations from the anesthesiologists and from the patients and from the hospitals. So that has to be considered before developing any new drugs. So in this era, one major finding is that hypertension is more than what we think. It is a very deleterious phenomenon during the perioperative period. So a mean arterial pressure less than 80 millimeters of mercury for more than 10 minutes, that itself is can be said as a threshold where an organ injury mechanism starts. So you should always try to prevent hypertension, be it comes because of blood loss or be it from when you administration of a large dose of propofol. So don't take it lightly. Every time try to correct it with vasopressors, because that has an impact on patient outcome. Another concern is postoperative delirium. It is a very vague term which most of the practitioners may not give that importance. But it should be actually dealt in a very systematic way, and it is actually a perioperative neurocognitive disorder, postoperative delirium. So it is distressing for the patients, it is distressing, it is challenging for the staff, and it is associated with impaired outcomes and also add to the cost. So always develop molecules which counter or at least don't have a promoting effect on postoperative delirium and other psychomimetic effects. That is one thing. Then, as everyone knows, acceleration of drug effect onset and offset. Offset is very much pertinent because we are moving to an era of ERAS, enhanced recovery after anesthesia. So in such a context, the offset time should be very fast. Otherwise, you cannot practice daycare anesthesia and rest. A clinician can easily understand what is the difficulty if the drug onset time is longer. So propofol, we all like one major factor because of our love towards propofol is it's faster onset. It has a very good offset profile also. But these are very basic requirements before developing a molecule. And postoperative nausea and vomiting. As you know, nausea and vomiting is a very distressing feeling, especially along with pain when the patient is recovering from anesthesia. So propofol is definitely an antiemetic, and even midazolam also has some antiemetic properties. Dexmedetomidine has antiemetic properties. Whereas the volatiles and other agents are just the opposite. So that is another feature desired of a new molecule, and the ability to support swift and atraumatic placement of a supraglottic airway. Just like I mentioned, ERAS is the path through which we have to move in the future. So in such a scenario, replacing the endotracheal tube, which requires relaxation and other long-acting drug administration with the supraglottic airway is very important. And many of the surgeries and anesthesia require only a SGA insertion. So like propofol, the new molecule also should be able to support a HGA placement. For example, if you consider thiopentone, it doesn't have any airway reflex suppressing properties, whereas propofol has an excellent added advantage in that area. So new drugs should be like that. So these are the expectations which the anesthesiologists and patients keep in this new modern era. So coming back to the previous question, how is our existing drugs performing? See, all the main drugs, be it propofol or thiopentone or etomidate or ketamine or dexmedetomidine, they all have pitfalls. But these are few names which didn't become a failure. So in this table, I have mentioned on the right side the major side effects with these drugs, but those which underlined, they are the main cause of commercial failure or concern. In this case, it is not failure, but with a commercial perspective, what is mostly disliked of these agents, those things which I have underlined. For example, coming to etomidate, the major effect any anesthesiologist resident will tell first is its adrenocortical suppression. And when you use in practice, you can see and the patient can experience the very unpleasant, inconvenient muscle movements, excitatory muscle movements. But from commercial perspective, the most negative point about etomidate is postoperative nausea and vomiting. Like that, propofol, even though it produces so much hypotension, one very much disliked aspect is the pain on injection. Ketamine, it is hallucination. Dexmedetomidine, it's bradycardia and hypotension. And thiopentone was a god in anesthesia for a long time. But this is taken from a BJ article. Thiopentone has been removed from the WHO model list of essential medicines and is no longer available in the USA after physician and pharmaceutical industry rejection of its use in judicial killing. In Europe and elsewhere, thiopentone remains available and locally popular, but repeated accidental syringe swaps for antibiotic or local anesthetic and clinician unfamiliarity have driven obstetric anesthesiologists towards propofol. So that is the fate awaiting thiopentone also. So, so you can see that if you see the sitting lineup, there are a lot of lacunae. And we were not just couch potatoes. We were trying to develop a lot of drugs, the anesthesia researchers, but many of them failed. Whenever you tell about drugs, the failure stories are also important, but because it gives you lot of directions for moving forward. So this steroids, whether steroids can be used as an anesthetic. So that question may not have come very popular, especially maybe post 90s. But before 90s, there was intense research on using steroids as anesthetics. Those are known as neurosteroids, neurologically active steroids. So pregnenolone alone was used as an initial step, but the major problem it posed was the urticarial rashes. So it became a failure because of that. And quite some time back, we had heard a lot about forced propofol, but why it didn't come up? Because it was causing significant perineal pain. When a drug causes such issues, it is very difficult to popularize it, especially when you don't have any remedies to counter such issues. And the ABP 700 or an atomidate derivative, I have put a star because it was a failure, but it is not a failure because it has come back in a different form. So previously, the problem was the carrier used to deliver that drug was the cremaphorel. So this caused a lot of anaphylaxis, which were deadly. So that's why from 1970 to 84, it was in use, trying to establish its position, but because of this major side effect, it failed. And can we use volatile agents for sedation? No, because there is a lot of need for scavenging. Then that can arise equipment issues. Then sedation with sevoflurane may cause diabetes insipidus if it is for a prolonged duration. Then sometime back, we had also heard about this SCTIMST, semi-autonomous drug delivery system, but it also never came up because it lost out to in-person care. So this is the background in which we asked the question, which are the newer drugs that expect its entry into the front stage in our anesthesia practice. So I'll be dealing only with the molecules which has come up with proper studies or which captured some space in major journals. Other prospective molecules, it's not that useful because we have already seen a long list of drugs which failed. So many of these things may not come into practice. So I'm not dealing with those drugs. So I'll be dealing with the ciprofol, remimazolam, alfaxalone. Alfaxalone is a neurosteroid, esketamine, etifoxine, and ABP 700. Sorry, there was one mistake. ABP 700 is an atomidate analog. It was not a neuroactive steroid. I just sorry for the mistake. It was a problem with the slide entry. So another thing which I would recommend is, especially the residents, whenever you are discussing a drug, you should follow a order. That is, we should tell about the introduction and the group details of the drug first. Second, you should discuss about the uses. And thirdly, should tell about chemical characteristics, how the drug is presented in the commercial market. Mechanism of action, and then should come next. Then route of administration and dosing. And then you should tell about what the body does to the drug. That is absorption, distribution, metabolism, and excretion. That is pharmacokinetics. Then you should tell about what the drug does to the body, pharmacodynamics, CNS, CVS, GIT, renal, metabolic, musculoskeletal, etc. All systems you should describe. But in today's discussion, we won't be discussing this much detailed pharmacokinetics or pharmacodynamics because they are new drugs and such data are not available. Pending more pharmacokinetic and pharmacodynamic studies. After that, only such details will come in such purpose journals. And we should then discuss about side effects and then about special points. So I'll be dealing each drug in this order. Coming to ciprofol. So first you should introduce the drug. It is a structural analog of propofol. and it is an intravenous anesthetic agent. That should be your introduction. Then you should tell about the uses. So the US FDA and European Medical Agency are the major authorities which gives approval for certain use of certain drugs in clinical practice. And nowadays there's a entry of the Chinese scenario also into clinical practice, because post-COVID, if you see journals, a lot of Chinese articles are taking its place in major journals, be it JAMA or BJ or Anesthesia Analgesia. Everywhere, China is trying to present its voice. So the National Medical Products Administration, that is the organization in China which gives approval for these drugs. So they have given, I feel like it is very easy to get a permission compared to other FDA or EMA in China, because whenever you see a drug without any approval from FDA or EMA, but you can see the approval from China. So in case of Ciprofol also it is same. It is approved in China for sedation and induction of anesthesia. So that is the second, that should be the second heading. Then you should come about chemical characteristics and presentation. When you compare Ciprofol with Propofol, there is not a major difference in the presentation. So that is one point which the Ciprofol dislikers use as an argument. So there is still continued use of lipid formulation, but definitely with lesser lipid exposure with the 1% emulsion. And under the same conditions and at the same concentration, Ciprofol has a lower free drug concentration in the aqueous phase. This leads to a lesser incidence of pain on injection. This is the major highlight of Ciprofol. It has comparatively less pain on injection compared with the Propofol. Also, less solvent is required. Coming to the next heading, mechanism of action is same, but it has stronger affinity to the GABA-A receptor. So that may translate into a more potent drug. And rules of administration and dosing, there is no definite range which we can tell actually, because it is not FDA or EMA approved. But from studies, you can detect certain values. So of course, the administration is IV, and the dose described in one article is 0.15 to 0.9 milligram per kg. And another article, it is 0.4 to 0.9 mg per kg. So as expected, it is these are from Chinese articles. And in the pharmacokinetics section, you should tell about absorption, distribution, metabolism, and excretion, ADME. So coming to Ciprofol, we can't present this detailed data here because we don't have information. And this is 4 times, Ciprofol is 4 to 5 times more potent. That means less dose requirement. And when you are giving a less dose, the respiratory system and cardiovascular system side effects are less. So that is about Ciprofol pharmacokinetics. Coming to pharmacodynamics, see, if you compare side by side, you can see that Ciprofol has a slightly longer duration of action with a less rapid recovery compared to Propofol. That was the picture we got from the available studies. And side effects, it is you can see in the literature the response is mixed. So some articles say it has a similar adverse hemodynamic impact to that of Propofol, but some other articles say the serious side effects are less and with a less severe respiratory depression, and definitely significantly less pain on injection. So finally, coming to the special points. So Ciprofol is currently undergoing late-stage clinical trials for procedural sedation, and trial registries indicate studies in general anesthesia also. But however, none are yet reported. Given that, so one sort of argument is this. Given that pain on injection of Propofol may be attenuated by co-administration of lidocaine, the case for Ciprofol remains unproved. So only time will tell whether it becomes a champion, just like propofol, or it is just another forgotten drug, whether it will become a forgotten drug, just like the agents which I discussed in the initial part of the presentation. So that only time will tell. So the major summary is definitely less pain on injection, and a few articles describe lesser impact on CVS and respiration. Coming to the second drug, remimazolam. It is a short-acting benzodiazepine, and it is an intravenous anesthetic and sedative agent. That should be the introduction. And uses in US and China, it is approved for procedural sedation, and in Japan and South Korea, it is approved for anesthesia. Chemical characteristics and presentation. So the left side picture is of remimazolam, and the right side is midazolam. So you can see an additional branch in the remimazolam figure. It is an additional rest linkage. That is the difference between remimazolam and midazolam. Remimazolam undergoes hydrolysis by carboxyl esterase 1. Hydrolysis by carboxyl esterase 1 to an inactive metabolite. Midazolam is converted to the active metabolite alpha-1 hydroxymidazolam. So this byproduct of midazolam has still strong affinity for the GABA A receptor. That is the root cause of the problem of delayed recovery with the midazolam. But here, because of the ester hydrolysis, the elimination of the drug would be expected to be fast. And mechanism of action is similar to midazolam only. Routes of administration and dosing, IV, it is 5 mg over 1 minute, followed by necessary by top-up doses of 2.5 mg. Coming to pharmacokinetics, as I already told, it is a esterase hydrolysis. So that will lead to a faster metabolism and clearance of the drug from the body. It has a marginally greater potency and a maximum effect compared to midazolam. So it is slightly more potent. The principal metabolite of remimazolam binds with 4-10 times lower affinity than its parent and is considered inactive, whereas the midazolam metabolite is having stronger affinity for the GABA receptor. So here the clearance is fast. High first-pass metabolism with consequently near zero oral bioavailability. So you cannot use it as a oral drug. Pharmacodynamics, it has a swifter onset and offset. That is the reason why it came into a lot of discussion and research, because midazolam was not having that profile. Otherwise, it is broadly similar to midazolam. And when you compare with the standard benchmark propofol, the onset is slower compared to propofol. So it cannot beat propofol in the onset time, but offset is somewhat similar to propofol and grossly improved compared to midazolam. It is not a midazolam, but it is a propofol in case of offset. And it gives a stable BP and heart rate. As I already told in the initial part of the presentation, hypertension is a major enemy for the anesthesiologist if you have a very strong intent to improve patient outcome. So in that regard, if you compare with propofol, remimazolam has a very stable hemodynamic profile. So that is one major advantage. Side effects, lesser incidence of hypotension. Respiratory depression or hypoxemia incidence is somewhat similar to or slightly less than midazolam. So coming to the left side of the left picture. So the bold black line is remimazolam, whereas this heavily dotted blue lines are midazolam. This is what to say, thin purple dashes. This is of fentanyl. So you can see that this one, that is remimazolam's graph when it is plotted with the time on x-axis and the peak effect on y-axis, it lies between that of propofol and fentanyl. So you can imagine the profile of its onset with this graph. So it is between this. 1 second. So it is between fentanyl and propofol, whereas it is the midazolam lies quite towards the right side of the graph. So that is why it is not used as an induction agent. Coming to the right side picture, this here you can see contact sensitivity half-time plotted in the y-axis and duration of infusion on the x-axis. So this blue line is propofol is large red dots, and this is remifentanil. And here comes the black straight line is that of remimazolam, and you can see where the midazolam graph is lying. You cannot find out the contact sensitivity half-time for midazolam. So it goes on prolonged to very high values. So you cannot expect a patient to come out easily after a long duration of midazolam infusion. Whereas finally we have found a benzodiazepine drug which has some similarity in the contact sensitivity half-time plot over time to both remifentanil and propofol. So that is the advantage of remimazolam. It has a reliable contact sensitivity half-time that will not get higher and higher with ongoing infusions. So this was one study came in 2020 in Journal of Anesthesia. So here they have randomized the patients into 3 groups. One is, for the first group, they gave remimazolam at 6 mg per kg per hour. Second group received 12 mg per kg per hour. And third group received propofol 1 mg per kg per hour. Propofol 2 to 2.5 mg per kg bolus dose. And both groups received remifentanil at 1 mg per kg per hour after the induction phase. And here what I found out was, so the 3 groups, 6 mg per kg remimazolam, 12 mg per kg remimazolam per hour. So remimazolam was given as an infusion, both for the induction and for the maintenance, whereas propofol group got propofol as a bolus for induction and followed by a remifentanil maintenance. So here what they got was the remimazolam onset was 120 for the 6 mg per kg, 120 seconds for the 6 mg per kg group, 88 seconds for the 12 mg per kg group, whereas it was 78 seconds for propofol group. So you can compare the onset times from this. As already told, it is slightly delayed for the remimazolam group. And they observed a less hypotension and less use of vasopressors for remimazolam. Equally less postoperative nausea, vomiting, and no awareness for both the remimazolam and propofol groups. So the PO profile was almost similar. But during the extubation, you can see that remimazolam group had an extubation timing of 15 minutes and 18 minutes, whereas propofol had it for 12 minutes. And the time to recovery room, time to discharge from the recovery room was 25 minutes for the remimazolam group and 16 minutes for the propofol group. So there is, you can see, a slight deviance from the propofol's nature in case of remimazolam. And they have continued this study. This study was conducted in ASA 1 and 2 patients. Then subsequently they continued the study in ASA 3 patients also, where they found excellent tolerability in compromised patients. So the special points yet to see the proceduralist and the patient satisfaction with the non-anesthesiologist remimazole sedation versus that achieved by anesthesiologist provided propofol sedation. So when you develop a molecule and it finds some place in the main clinical scenario, then the next question is whether a non-specialist can use that drug. So that will help the clinical practice in a better way. For example, if propofol was a drug which can be used by the medical gastroenterology people without any anesthetic assistance, they would have given all the sedation for endoscopies themselves. So there was no need. So it would have reduced a lot of load on the anesthetist. So in that way, there has been attempts to use remimazole by non-anesthesia specialists. So is that possible? Time only will tell. The possibility of reduced perioperative hypotension may be the most rational reason for considering remimazole, especially with opioid, for induction and maintenance of anesthesia. And but one problem is this was the major study which I previously mentioned, which came in which compared remimazole in anesthesia, induction and maintenance, and it has not been evaluated for induction of anesthesia followed by an inhalation maintenance. In such a scenario, it has not been tested. In comparison with propofol, the relative hemodynamic stability which we have seen with remimazole comes at a cost of minimally delayed loss of consciousness, but materially slower recovery. And another question is, the benzodiazepines are not the preferred drugs in ICU practice anymore because of the chance of increased causation of delirium. So what is remimazole effect in this area? That has to be seen. And for the time being, it is not reserved for use by anesthesiologists. Means it can be used by other specialists also. But the problem is, see, there is a lot of caveats in this approach, because it is better that the whoever uses remimazole, they need better training and they have a good knowledge about the pharmacological profile of the drug, because it is not a case of safety every time. Especially when you are using with a fentanyl, for example, they are doing some procedure in which patient has some pain. So they give some fentanyl and then they continue the remimazole. The picture is different. So there can be respiratory depression, which the non-anesthesia specialist may not be able to tackle properly. So it's better that any specialist needs enough training before handling this drug. Even though it is currently, they can use it for the time being. Coming to the third drug, alfaxalone. So this was a neuroactive steroid. This is a neuroactive steroid. So I don't know how many of you know Fahad Fasil. He's a Kerala actor. He has come as a hero in a movie before 2000s. It was a very big flop. Actually, he didn't create any impact. But afterwards, after a few years, he came in a different outlook, and the rest was history. So he became a major hero in Mollywood industry. So like that, the neuroactive steroids, they were used from 1972 to 1984. So it was a drug which was tried for anesthesia in such a long period. Then what happened? Where were you? So neuroactive steroids are steroids with anesthetic effects. It is a steroid which has direct effects on receptor targets in the CNS, and which modulates neuronal excitability also. So the major compound which came in practice was and is alfaxalone. When it was previously administered in a different carrier vehicle, that time the problem was severe pain on injection and thrombophlebitis at the injection site. See, whatever you see a very good peri anesthesia drug profile for the drug, no hypotension, very easily titratable. And that all should be okay. But if during the awake phase of the patient, if the drug is causing any side effect, it will not be tolerated by the patient and the commercial setup. That's what I told. The commercial perception and the clinical perception are different. So this drug had that kind of problem. It caused a lot of pain. And again, to improve the stability of the molecules or improve the lipid solubility, the water solubility, they found different ways of modification of the molecule. And finally, it was administered with a castor oil vehicle known as cremaphorel. So this particular component of the drug was the deadly anaphylaxis. That was enough to withdraw it from major use. So that's how it disappeared during 80s. And then the US FDA approved a molecule called the beta-cyclodextrin, which is a cyclic oligosaccharide for use in enhancing the solubility of non-water soluble compounds. So when this was carried by beta-cyclodextrin, when alfaxalone was carried by beta-cyclodextrin, the profile changed. So the vehicle was replaced by beta-cyclodextrin. Now it is finding some use in anesthesia. So coming to the introduction, it's a neurosteroid, neuroactive steroid. And it is a progesterone analog without any steroid effects, devoid of progestational, estrogenic, glucocorticoid, mineralocorticoid, and thymolytic activity, and is an anesthetic sedative with anticonvulsant and neuroprotective actions. So it has some more things to project as advantage against the existing lineup. And the US, there is no approval from FDA or EMA. It is an IV hypnotic, which is used in certain studies. Chemical characteristics and presentation. It is a 5-alpha and 3-alpha reduced neuroactive steroid reformulated in beta-cyclodextrin, and the brand name is Faxan CD. It was and also is in use in veterinary anesthesia. So, so we had a long history for this particular molecules use in the clinical field, but only thing it was in veterinary anesthesia. It comes as an aqueous solution in as 10 mg per ml in 30% 7-sulfur-butyl ether beta-cyclodextrin formulation. And the mechanism of action is, it is still just like the other anesthetics. It is a GABA A receptor modulator, and it has also actions at some other receptor sites like voltage gated calcium channels. So it has, since it is a totally different group, you can expect the mechanism of action at some extra things compared to the existing drugs. Group, it is an intravenous anesthetic, and I already told, and a sedative. And route of administration and dosing, it is from a study conducted by Goodchild et al. It is 0.55 mg per kg. Pharmacokinetics, it's faster onset and recovery. That is the advantage of alfaxalone. And pharmacodynamics, it has excellent hypnotic effect. It is somewhat like propofol, but with a less hemodynamic impact. And that definitely will raise a good perception about the drug. And you can see significant burst suppression EEG, and certain, even if it is few, the studies have used a BIS monitor for measuring its depth of anesthesia. It produced a substantial decrease in cerebral blood flow. So whether this crosses the line and causes a physiological destability is to be known. With further studies, it may come up. And side effects, it produces transient tachycardia and slight hypotension in some of the studies. Another advantage it has to speak about is the lack of neurotoxicity in the young brain. Most of the other drugs in animal studies and other trials, they post at least they post a threat of causing some neurotoxicity in the developing brain. But this being a steroid, it was not having any effect on the younger brain. Any deleterious effect was not there. Special points in non-human primates, alphaxalone is preferred to ketamine due to its ease of emergence as well as the quality of anesthesia on muscle reflexes and vital signs. So that's about alphaxalone. And this was the major study which was done by Colin S. Goodchild. It was published in Anaesthesia Analgesia in 2020. And following this, a phase 3 study also came up, but I could not find it in the literature, means in the internet. A phase 3 pilot study in anesthesia analgesia suggests that the favorable characteristics described in volunteers are repeated in patient care also. There they studied in actual patients. So the favorable characteristics continued there also. So it is a promising agent, alphaxalone. It's a neuroactive steroid. Coming to the fourth molecule, S-ketamine. It's the S enantiomer of ketamine. So, sorry, the picture was the previous picture. Don't look at it. S-ketamine, the introduction group, this is an intravenous anesthetic, S enantiomer of ketamine, and it's a sedative also. Uses, FDA has approved it only for use in depression. And the European Medical Agency has approved for anesthesia. And in China, NMPA has approved for perioperative sedation and analgesia. Coming to the chemical characteristics and presentation, it's an enantiomer of ketamine, the same phencyclidine derivative, no changes. You can exactly tell what you would tell for ketamine. Mechanism of action, it's an antagonist of NMDA receptors. It has 4 times more affinity to NMDA receptor and also has affinity for some mu opioid receptors. So that may cause some change in its profile compared to ketamine. So it is more potent compared to ketamine. Routes of administration and dosing, IV 0.15 to 0.5 mg per kg. And one study in, I think it's in VJ, they found a ability of S-ketamine to reverse the opioid-induced respiratory depression in certain patients between doses 12 and 24 mg per hour. They gave it by infusion, and when they kept it 12 and 24 mg per hour, it reduced the opioid fentanyl-induced respiratory depression. So that is another property. Pharmacokinetics, rapid onset of action and rapid awakening. That is quite a difference compared to ketamine. It can be used to reduce the dose of propofol during sedation, reducing the latter side effects. Exactly like we use ketofol, this can be used in place of ketamine in the ketofol component, ketofol combo. And you can expect a further better pharmacodynamic profile if you use S-ketamine in place of ketamine in ketofol. So that is the advantage. And there is, and since it is a potent drug, it will again provide excellent analgesia, more than that what is given by ketamine. Coming to pharmacodynamics, there is significant reduction in opioid dosage because of the above said reasons, and pain scores after S-ketamine supplementation. But the effects did not persist after the first 24 hours. So they studied the impact in pain profile after in the postoperative period. And 2 studies found the effect lasted only till first 24 hours, and it caused mild respiratory depression and dilated bronchi is just like ketamine, it causes bronchodilation, and it is a more potent analgesic. These are the pharmacodynamic features. Coming to side effects, with intraoperative administration, there were no obvious airway secretions, less psychotropic side effects compared to racemic ketamine, no increase in PONV, and with the post-operative administration, actually, so when you give it during the intraoperative period, what I said till now was the effects. But if you are continuing to give S-ketamine in the post-op period also, then you will get excellent analgesia, but with more psychotropic side effects. So that was about S-ketamine. Coming to the next molecule, ABP 700, is an etomidate analog, which is not a neuroactive steroid. Sorry for the mistake. It is an etomidate analog. And the group introduction, second generation analog of etomidate, developed to retain etomidate's beneficial hemodynamic and respiratory profile, but diminishing its suppression of the adrenocortical axis. And it was developed for induction and maintenance of general anesthesia, just like etomidate. Chemical characteristics and presentation. Cyclopropyl methoxycarbonyl metomidate. It is known as CPMM or ABP 700, or the brand name is MDCO 700. It comes as 10 mg per ml and with a 10% sulfur butyl ether, B-cyclodextrin with meglumine, an amino sugar derived from glucose in a 20 ml USP type 1 clear glass vial. Since it's an experimental compound, not in popular use, that's why I'm detailing a little long about the preparation. Mechanism of action, just like etomidate, it is a GABA A receptor agonist. Routes of administration and dosing, IV, 30 to 60 microgram per kg per minute. That was the dose used in a few studies. Bolus doses of 0.25 mg per kg and 0.35 mg per kg are found to be the most optimal doses in this 30 to 60 range for induction of anesthesia. Coming to pharmacokinetics, it has a rapid onset and rapid metabolism. That is due to rapid hydrolysis of an ester bond. And it has a rapid recovery from the hypnotic effect. Coming to pharmacodynamics, it has a longer duration of action with a less rapid recovery. And the modified observer's assessment scale of sedation and as patterns did not always follow the BIS profiles closely. So there was some discrepancy between the clinical depth of anesthesia and was shown in the BIS monitor. So such a discrepancy was there. We will come to know about the reasons behind such scenes in the future only. Side effects. Adrenocortical responsiveness was not significantly different from that after propofol infusion. That's a great thing. Like you can administer an etomidate analog just like propofol with view to the adrenocortical suppression profile. So stimulation with the ACTH in such patients, it caused a physiological cortisol response thereafter. So it didn't cause any adrenocortical suppression. So finally, they are able to produce, there come a lot of etomidate analogs. Many of them did not have adrenocortical suppression, but actually because of other issues, they failed in the market. So now they came up with a compound which is reasonably good in 360 degree. Dose-related involuntary muscle movement, that is again there. It was not of high incidence, but it was still there in a certain proportion of the patients. So involuntary muscle movements is a disturbing problem. It continues with the ABP 700 also, and the treatment is midazolam. And during these periods of involuntary muscle movements, there came a tachycardia and tachypnea also. So they are also can also be labeled as other side effects. One problem with this is if you are using this for sedation or something, this involuntary muscle movements can cause airway obstruction in a vulnerable patient who has OSIS or a very collapsible upper airway. In such patients, this can cause airway obstruction. And severe hypotension or severe respiratory depression was not seen. And here the very interesting point which we all should know is that etomidate, if somebody asks you its prime effect, it is actually an adrenocortical suppressant. The anesthesia is a secondary feature only. So it's such a drug provided lots of hemodynamic stability in compromised patients. That was the reason why such a drug with such bad effects is still persisting in anesthesia practice. But its major effect is adrenocortical suppression, and hypnosis is a secondary trait. So it is a multi-effect combo. It can be viewed as a toxin plus very life-saving drug in anesthesia practice. These are the group, the Walk et al. They studied safety and clinical effect of IV infusion of ABP 700, a soft analog of etomidate in healthy subjects. Soft drugs are the current passion among anesthesia researchers. They are trying to produce anesthesia drugs which has a rapid onset and a rapid offset because of some mechanism like rapid metabolism by esterase, etc. Soft drug development is the booming thing in anesthesia nowadays. And so from this discussion, you can see that a proper assignment of roles for each drug is very important. Some drug will be good for administration before volatile maintenance. Some drug will not be good at all in use during anesthesia induction and maintenance, whereas it has a very good profile in the ICU. So you have to select, and even during the trial phase, you have to design your trials accordingly. A drug which is obviously not suited for induction or maintenance, why to try such a drug for in upcoming trials for the same thing? Instead, you try those drugs in the for ICU use. So the proper assignment of roles is a definite requirement while drug research and during clinical practice. And if you mention about other drugs, the Saber bupivacaine and HTX011, sucrose acetate isobutyrate extended release bupivacaine, that is Saber bupivacaine. It's a biodegradable depot drug. It has the capacity to hold a high concentration of bupivacaine up to 660 mg, but it contains benzyl alcohol and cannot be used for perineural use. It is neurotoxic. Coming to HTX011, is a biodegradable polymer mixture of bupivacaine and meloxicam. It has been investigated as a means of delivering long-lasting infiltrative pain relief after hernia and minion surgery. Phase 3 infiltration studies show better pain relief compared to bupivacaine and extended time to first analgesic rescue. And trials of HTX011 for nerve blocks are awaited. So it can be used for nerve blocks, so studies are awaited. Quaternary lidocaine, QLD plus vanilloids. So quaternary lidocaine, it's a charged molecule that cannot pass through lipid barriers. The primary afferent nociceptive neurons have something known as transient receptor potential, TRP ion channels. TRP channels are activated by the vanilloid capsaicin. So this channel has to be opened for this QLD to enter the cell or enter the neuron. So somebody has to open the channel. So this can be opened by the vanilloid capsaicin, thus providing an aqueous route for the entry and binding of QLD to the voltage gated sodium channel. So you have to give vanilloid along with the drug. But the problem is the use of capsaicin is limited by painful irritation. So I don't know how these studies about QLD will come up. Animal studies, it has shown prolonged analgesia with less motor block than equivalent doses of lidocaine. And another interesting thing is the reversal of local anesthesia, especially in dental practice. Persistent numbness, drooling, and inability to eat after local anesthesia for dental surgery are unpleasant. So phentolamine mesylate is a non-selective alpha-adrenergic antagonist that causes vasodilatation. So when you vasodilate, the drug will get washed out. So this increases the blood flow and is reported to halve the reversal time of local anesthesia. So that's all about newer drugs. And there's a lot of materials in the internet to read about. I recommend you search in the Google Scholar or Google with the search word like the particular group, or when you search the particular group name or drug name, BJ, like neuroactive steroid BJ, then you will get a better article. The BJ and other high quality journal articles give you a lot of lateral thinking opportunities. So such journals should be preferred compared to some other review articles which has which are quoting data based on lower quality evidence. So that's my recommendation. Thank you for your patient listening.
Thank you very much, sir. Really a very difficult topic. You've dealt it so nicely, and you have kept what is to why your presentation in focus, what is needed and what has been developed. One question from Edward sir is that whether this sulfaloxone will can be used in diabetics because it's a steroid molecule.
I think with extensive search also it will be difficult to find specific answers about giving such drugs in sub scenarios because the studies are in its initial phase only. So we will not find they have just stepped up from the animal studies to the human studies. So whenever and mostly they will be using in ASA 1 and 2 patients. So a significant proportion of diabetics might not have come in their study groups. So such like subgroup data we may get after quite some time only. I think so. So I could not find out any data regarding use of alpraxolone in diabetics.
Can I give
And
the answer of this question to Edward? Yeah, Edward, actually what happens even if you use steroid itself, like dexamethasone or any type of hydrocortisone. So there are studies, extensive studies done in the anesthesia, during anesthesia, pan-anesthesia period, that if the basic blood sugar is around 110 in the morning, FBS period in the patient, then if you give the 8 milligram or 100 milligram of steroids of hydrocortisone or dexamethasone, it increases only 12 milligram to 16 milligram of the sugar level in that patients by only drugs only. So one dose cannot give any problem with the giving this anesthetized patient, whether it is a steroid itself or steroids like the anesthesia induction agents. So particularly in my scenario, when I'm doing any sort of anesthesia practice, I usually give 6 to 8 milligram patients, even diabetic patient, because if their sugar level in the morning level is under control, then there is no need, because there are a lot of advantages of giving steroids rather than not to give steroids. So I am in that school thought that whether we should give or not, it is not a problem. But when there is a higher advantages to give, no doubt, continuous anesthesia with the another drug, if it is increasing, then we cannot give. But stress of the anesthesia, surgical stress may increase the blood sugar level. So we have to monitor during the operative period also. So that is the way I usually give in my all patients.
Okay, sir.
We are routinely using steroid during induction, 8 milligram. So in our department, we are conducting a study whether the 8 milligram dexamethasone given at the induction in non-diabetic patients, how much blood sugar increased in the course of.
So that's a good experiment.
Yes, sir. We have to study it, sir. Otherwise, there are varying thoughts whether to give it or not give it. And it's mainly because of the concern about the postoperative hyperglycemia. Only if we study, we'll know it, sir. When it's done, please let us know, sir.
Yeah.
And Unnikrishnan, sir, as you said, China is coming with a lot of research and molecules. I think recently I read about another drug like Sugamadex. They have developed it and they have tested it, and it's almost out of phase 3 trial also, sir, for reversal of all steroid neuromuscular blockers.
It is Adam Gamma-dex. It is called
yes,
Adam Gamma-dex.
Adam Gamma-dex, yes, sir.
Yes.
Adam Gamma-dex, yes, sir. I think they are more into drug research and bringing out drugs.
Chinese people are coming lot of drugs in the invention. Even they are
Yes,
coming
sir.
with a lot of gadgets also.
And they are publishing in journals like JAMA. See, actually, JAMA and all require around 2.5 lakhs to 3 lakhs publication charge. So when you get that and you find that the study reasonably good, then they may be accepting the article. I think so. That's why, and if you deeply dig into the article, you can see a lot of pitfalls in the study design and all such the Chinese articles. But still, they are finding entry into all the major journals.
True, sir. But anyway, today it was a very nice, refreshing topics. And true to this update, we had all new innovative things. Hearing this for the past 2 hours, sir. Thank you, Tushar sir, and thank you, Unnikrishnan sir.
Thank you,
Thank you, all
everybody.
viewers. Have a good Sunday.
Thank
Thank
you,
you, Edward, sir.
Thank you,
Sivaprasath,
sir.
for your coordination. And
Thank
thank you, Unnikrishnan sir. It's a wonderful, complete presentation with a lot of information. It will be more useful to the postgraduates. Please share your slides. Then I can share it to the postgraduates.
Yeah, definitely I will share.
Thank you,
Thank you,
Tushar,
everyone.
for your mind-blowing presentations. Today we have very good presentation by both speakers, Unnikrishnan and Tushar. I thank the speakers and also the sponsor, Akrula, and the co-host, that is Anaesthesia TV and A1 Logics. Thank you, one and all. We will meet next week with more. Still
Thank
more.
you, everyone. Thank
Good
you,
day.
everyone.
you, sir.